Good afternoon, everyone. Welcome to our session today, and thank you for joining us for today's webinar on building protective breastfeeding environments using the Nourished Truth Operational Toolkit. We're just going to give about 2 minutes for everyone to be able to join in, and then we can start the session. I see everything is filling up quite nicely. Not to waste too much time, I think we can maybe just do some housekeeping. And just to introduce myself, I am Angelika Grimbeek. I work for the Healthy Living Alliance in South Africa. And once again, would really just like to thank everyone for joining today's session, and also to thank the Family Loss and Rosenquist Foundation, LactaHub, Amref International University, as well as the Global Health Network for making this webinar come to life. So while everyone is joining, just some housekeeping announcements. If you are having any technical issues, please can you just write it into the chat, and we will definitely try and help you out as quickly as possible. Your video and your audio has been turned off, so if you have any comments or questions or anything, please go to the Q&A box and write any kind of questions you have. We really want you to engage as much in the content and to hear from you. So please, we encourage you to really ask as many questions as you can. We are recording this session, and we will also have a recording available for you after the session that we'll be able to access. And then we'll talk about the certificates at the end, but there is a certificate of attendance that you can have at the end of the session with 80% participation, and we will then talk to that at the end. So we can go to the next slide. Thank you. So, today's conversation is such an important one. I think everyone that's joining in today understands the importance of breastfeeding and the importance of increasing breastfeeding rates throughout the world. But we know that this is not an easy task. Protecting and supporting and promoting breastfeeding really takes a lot of initiatives to be working. But this project, the Nourished Truth Project, which will be introduced to you today, and we really will go through all of the details, seeks to protect breastfeeding by fostering an environment in which women's breastfeeding choices are protected and shielded specifically from the commercial milk formula marketing that we're seeing. So we can go to the next slide, thanks. We are joined today by a wonderful group of experts from different parts of the world, and I will introduce everyone as we go. Next slide. But we really will be taking a deep dive into what this project was and how it was started, what the learnings were from the South African experience of being the opening partner for this, and then also taking a look into different perspectives. Can something like a Nourished Truth project be implemented in other countries or other contexts? So we'll be looking at Ghana's perspective. And of course, today we're also going to be introducing the Nourished Truth Operational Toolkit that has been developed for different countries, etc., to be able to try and start these projects and really try and get a good force of action against the industry and the marketing that we're seeing of breast milk substitutes. Next slide. So we have the privilege of having Prof. Alice Lakati, who is the Associate Professor of Public Health and Epidemiology and the Deputy Vice-Chancellor for Research, Innovation and Community Extension at Amref International University in Kenya today to open up the session. Thank you, Prof. You can go ahead.
Thank you, Angelika. Good afternoon, good morning, good evening from where you're joining us from. At Amref International University, we are delighted to co-host this session, this webinar that is focused on protecting breastfeeding. And because for us as Amref International University and Amref Health Africa, interventions like breastfeeding are within our DNA, because this is a high impact intervention that has been documented. Actually, there's no doubt about its role in reducing infant mortality, and actually quality of life. So at Amref International University, we are delighted to co-host this session. And I'm just going to spend a few minutes to tell you about Amref International University and why we are working with the LactaHub, Family Larson Foundation, the Global Health Network, and all the partners who are here to lead this webinar. So Amref International University, we were established in 2017 and got chartered in 2025. So that tells you that we look young, but as a university, we have been a training center in the past, having grown from Amref Health Africa that has been providing primary healthcare services in the region for 70 years now. We host this webinar ahead of an upcoming event that will also provide a platform for this Nourished Truth to be well understood within our setting in East Africa. So as a university, our vision is that Africa will have a skilled workforce that leads evidence-based interventions for lasting health change. The picture you see there is where we are located in Nairobi. That is our campus. And I'll just be talking ahead about why this picture is there. Next slide. As we come to speak about, before I hand over this to the main content of the webinar today, I would like to take this opportunity to let you know that Amref International University would be hosting the second Primary Healthcare Congress on 4th to 6th March in Nairobi. For us, breastfeeding is a primary healthcare intervention, and this actually fits very well within the theme and the sub-themes. So the overall theme of the Congress is redesigning primary healthcare, building resilience amid global uncertainty. As a university that has grown from an NGO that has been there for 70 years, we have seen that the only way to achieve health is by promoting interventions that actually allow communities to achieve health, one of them being breastfeeding. So I invite you to join us in this Congress, whereby we will be looking at the 5 sub-themes. One of them is harnessing technology to enhance primary healthcare service delivery. The second sub-theme in the Congress is looking at sustainable financing for primary healthcare in a changing global landscape. I think we all recognize that with the change of funding, African governments have to think about how to finance themselves. The next sub-theme is looking at primary healthcare interventions towards achieving universal health coverage. And this is actually where this webinar fits very well into sub-theme number 3. Sub-theme number 4 is looking at strengthening leadership, governance, and accountability to unlock primary healthcare transformation. And finally, global health security. So I invite you to join us next week, actually from Wednesday, to meet a number of partners in this Congress. Next slide. What do you expect from this Congress? We are going to expect we are hoping to have over 200 scientific and best practices abstracts presented by early career researchers, by senior researchers. For us as a university, we want to give a platform to early career researchers and senior researchers to work together. You will also have an opportunity to meet over 500 delegates from Africa, actually 35 African countries, Europe, the US, and Canada, as well as Australia. In addition to that, we are also going to have a session in the Congress among the 17 partner-led sessions. So one of the sessions that we are going to have in the Congress is building protective breastfeeding environment using the Nourished Truth. So this webinar comes actually ahead of that. So come and join us and interact with the panelists that you will hear today. We will also have representation from 6 universities. We are working with a number of universities from Eastern and Southern Africa, and you will engage with 27 local and international organizations. Next slide. So as I come to the end, we have so many partners that we are working with. So I invite you to join us in Nairobi on 4th to 6th March. You can click on that link that is there, and you can already see the number of partners who are going to be with us. So indeed, we are excited to be part of this network, to be part of this collaboration, to co-host this webinar. I hand over to Chantell.
Thanks, Prof. Lakati. I'm going to quickly jump in. So thank you very much for your insights. And really, I hope that we are going to see a wonderful representation from many, many people, especially in Kenya, for the conference. It looks like an incredible lineup of important conversations that are needed to do with primary healthcare as well as breastfeeding. So now we are going to really take a deep dive into this Nourished Truth project that we have invited everyone for. We're going to move on to unpacking why this project was initiated with Dr. Katharina Lichtner. Dr. Lichtner is the managing director at the Family Larsen Rosenquist Foundation, and very importantly, the Family Larsen Rosenquist Foundation was a huge strategic partner within this project in South Africa, as well as the funding partner. So, I mean, Dr. Lichtner, Family Larsen Rosenquist Foundation works in so many different countries to do with so many different elements of breastfeeding. So can you take us back a little bit to 2021, 2022, when all of this was coming to play, and just explain why was South Africa chosen, or why was this topic about the CMF industry also chosen at that time?
Yes, thank you, Angelika, and welcome everybody also from my side. It's really a pleasure to be here. Yeah, so this idea goes back quite some time. We were working, I think, as of 2019. God, seems like ages ago. We started working on operationalization. So I think by then, from the work, from building the strategy for the foundation, we have identified the gap between moving science into policy and defining the what and why something has to change and what has to change and what the target is and identifying the gap that we found that in many cases it wasn't clear how this could be achieved. So we can define what and why things have to be done, but the translation into how it's then actually changed on the ground, that was much less clear. So as we were building our strategies, as we were interacting with politicians, with scientists, with people on the ground, it became increasingly clear that there is a huge gap. So we had started around 2019 to work on that, try to understand conceptually how we can maybe help closing this gap, particularly for breastfeeding. And one of the persons I've been discussing this for many, many years was Nigel Rawlings from WHO, who has worked many years in his career also in South Africa before, I think, joining the WHO. And so we were discussing the merits and potential approaches of that question. And he pointed out that they're looking and at the same time, there was the big Lancet series in preparation that was done together with Sachi to look at how marketing is influencing breastfeeding. marketing of the formula companies is influencing breastfeeding. And it was clear from a conceptual perspective, almost from a policy perspective, what was happening. But what, again, was missing is, well, how do we translate that now into a viable campaign? And since this work was going on in South Africa, and I guess Nigel had a lot of connections there, the project was home there. He was wondering if we would have an interest to see whether this whole concept of turning something from the what and why into the how you actually do it, very practically, if this would also work for an advocacy campaign or if this can only be used for policy. So we were already working in Ghana at the time, working with the government, with the Ministry of Health, as well as a social enterprise, Ubora Quality Institute in Ghana. And in that context, also with Richmond, who's also on the call, to see how we can translate the breastfeeding policy of Ghana into an implementation plan, into a really holistic plan, which was in progress. And we had already made quite some progress on the conceptual understanding. And so out of the discussion with Nigel, we agreed that it would be really good to show that it can also be done with an advocacy campaign, because we believe it's one of the critical elements in changing the breastfeeding environment in every country. There's a lot of breaches, there's a lot of interference. I think Chantell will probably point that out in her part. It's not just the marketing, there's a lot of other elements, as we found in South Africa. And given that there was a lot of focus, good infrastructure, already a lot of people available that were familiar with the topic, we decided to go to South Africa.
Yeah, and I mean, again, even just looking back at the whole process, I remember working very closely with you and just how much you used to say we really have to think strategically. We are trying to combat a very well organized, very well resourced industry. Do you want to reflect on that a little bit? Maybe looking back at the project, what were some of the enabling factors? What were some of the challenges that you would maybe like to note that might be interesting for other contexts?
Yeah, I think the key enabling factors is having people on the ground that are familiar with the topic, passionate about it, and really want to make a difference. So I think it starts with the people. Then you can start building organizations, funding, strategy around it. If you don't have people on the ground that really are focused and want to participate in making a difference on that topic, there's not much chance. But and that was available. So we very fast could put a team together, and really had great leadership available. And that sort of formed the core. I think the complexity was and remains with this question is it's sort of at the interface between research and the practical side. And moving from research into practical is always a little bit of a challenge. That means you need to anchor yourself somewhere in a university context, because otherwise it will be very difficult to have it accepted in the public health space, and we continue to operate in the public health space. On the other hand, what you actually need to do is very practical. It's more like business planning, it's more like market research, it's more like strategic planning, prioritization. These are all things that are not necessarily embedded in the academic environment. And so this is what made it possible. The people on the one hand, we found a really good partner for the first part of the project, the development and conceptualization and phase with the University of the Western Cape, again, because we knew the people who happened to be in that university. So it was a choice for the people, and it should always be a choice for the people. And then you build the organizational part around it. And the complexity came out of managing this transition between needing some form of academic research and backup, and at the same time moving very strongly into the practical and strategic. And I think that's what makes it complex, but that's what makes it also extremely interesting. And I think it's a necessary step, because without that step, things get stuck in the academic. Why we want to see results on the ground that are tangible, which means per definition, it has to go into the practical. And to have a good strategic link between the two is really important for making sure it's not getting completely fragmented and disconnected.
Yeah. Thank you so much, Dr. Lichtner. I mean, these were really important reflections, and I think a lot of it will make a lot more sense for everyone in the room when Dr. Chantell Witten is going to now start the process of explaining how everything came about in South Africa. So thank you very much for your reflections. We'll hold a few more questions maybe that will come at the end. So again, just to encourage everyone to ask as many questions as possible in the Q&A. And now we're going to move on to looking closely at the South African experience. I mean, Dr. Lichtner has explained how we really needed the correct people, the correct hosts, everything in place to be able to actually create a plan for a campaign at the end. So we are going to ask Dr. Chantell Witten, who is currently the Health System Strengthening Director at Alifa Labatwana. But I think many of you who may know her as a very passionate breastfeeding advocate. And under the University of Western Cape, she led phase 1 of the Nourished Truth project and will be walking us through the context, the early phases of the project, and how the strategy started taking shape. So over to you, Dr. Witten.
Thank you very much, Angelika. And I'm going to pick up from where Katharina left off, because this was really very much a project of minds coming together, passion coming together, and a collective mission. I'm doing this presentation on behalf of myself and Bonnie Everett, who was also strategically part of the team. And both Bonnie and myself stepped off from phase 1. And so we are putting together this presentation from recall. And so I wanted to say thank you to her. Next slide, please. As with all presentations in the context of child health, I want to make a declaration around this presentation. We are drawing from our experience as the project staff at the time, and also from the collective efforts from everybody. And at this point, I also want to say a huge thank you to the Family Loss and Rosenquist Foundation and Katharina herself, because this was really co-created. The project did not start with a project proposal. This was not conceptualized before the team got together. And I think that was also one of the best parts of the projects that I've personally worked on. It was not prescribed. It had to be developed by the people on the ground. So very much thank you. And this is a collective of everybody, people that were in the project, people that participated as from the data we collected, as well as the context of the people working in this field, both in infant and young child feeding, and certainly in the field of food justice. Next slide. So let me jump into the presentation and the way I've structured it. I want this presentation to run alongside the handbook. So Angelika will speak a lot about the handbook in the next phase, but this particular presentation is in the first 3 actions of phase 1. So I'm going to be talking a lot around establishing the project, building the transparency, the analysis and the definition of the strategy, as well as the priorities of that first phase that fed into the second phase, which Angelika will present on. Next slide. So the backdrop of this presentation is particularly because South Africa had legislated the International Code on the Marketing of Breast Milk Substitutes. In our country, it was called the Regulations Relating to Foodstuffs for Infants and Young Child Feeding. It was already in place from 2012. And so that kind of gives you the setting of what were all of the enabling factors. So I'm going to set the scene for the project. I'm going to talk through how we pitched the project, both to the project participants in terms of our structures that we had, the project team that we built for this particular project, and then the technical side around the research process. As Katharina said, this was very much located in an academic space, but it did not require the rigidity and I almost want to say the safety guards that academia brings, because this was about operationalizing and trying to get to the systematic approach to how we may counteract the influence of the industry. And then from the data process, how we set the strategy and the priorities, and then hand over to Angelika for phase 2. Next slide. So This is a bit of a busy slide, but I think it's very important to give you context and for you to understand the landscape of the breastfeeding environment in South Africa. So I want to go all the way back to about 30 years ago, is that in the South African context, when we had our first democratic government, one of the first policies that was put into place was called the Integrated Nutrition Policy. And a fundamental of that integrated nutrition policy was a domain called Protect, Promote, and Support Breastfeeding. So breastfeeding was very high up on the government's agenda that time already. At the same time, during this early 90s, we had the advent of HIV. And at the time, UNICEF was working on the guidance, particularly in countries with high mortality, which is like South Africa at the time and in the African context. And that's where Nigel Rowlands was also working in South Africa, building the evidence base around HIV. And part of that evidence base was around infant and young child feeding. And then around about 1996, we had our first voluntary code for controlling the marketing of formula. In this voluntary code, it was both government and the industry sitting at the table coming up with guidelines that would suit both what government's objectives were and then also to some extent how industry was safeguarding itself. At the same time, WHO was putting guidance out around how to control the transmission of HIV from mother to child. And part of that transmission of mother to child was actually through breastfeeding. And so we knew that breastfeeding was a route for HIV transmission. And there was guidance at the time around replacement feeding. That's what it was called. And so between 1999 and 2011, South Africa's prevention of mother to child transmission of HIV actually provided HIV positive mothers free formula. So that is exactly about 12 years of free formula, meaning that it seeped into our culture, seeped into our dialogue, our narratives around infant and young child feeding. And formula basically became part of the package, part of how we took care of children. And then in 2010, WHO changed that policy with new evidence that showed that exclusive breastfeeding was not at a higher risk of HIV transmission. And in fact, it actually protected children from mortality, particularly in contexts where it was not safe to formula feed, meaning that we did not have safe, clean water, we did not have access to formula, we did not have the cultural context for formula feeding. We're very much a breastfeeding context in the South African context. And so there was a lot of conversations and research that was done, a number of large country studies of which South Africa was part of that. And that evidence showed that there is a place for exclusive breastfeeding. And that evidence informed South Africa's major landslide decision, which came in 2012. It was called the Tshwane Declaration. And in that Tshwane Declaration, South Africa committed to a number of milestones, including the regulations, legislating the code, the international code, which later became our regulations. It also stopped free formula. It positioned South Africa as a breastfeeding country, and it kept South Africa on the line of this promote, protect, which was committed to already in 1994. And so between 2012 and 2022, these regulations were in place. These regulations were communicated, but compliance was low. The knowledge around the regulations was very, very thin. It was not regulations that the lay public got to know about. It was mostly regulations that the nutrition fraternity was very au fait with, but the rest of the public health system was not au fait with the regulations. And so those regulations were really being flaunted, they were being violated. There were lots of reports of violations around how the industry was acting. And so the regulations, while they were in place, were not actually doing their job. And then in 2022, WHO, UNICEF decided on a 6-country, multi-country study, of which South Africa was one of that countries. And WHO was coming forward with all the evidence of how the industry was engaging, despite the regulations being in place. And then in 2022, we also had something called the Not Today Nestle campaign. And this was a groundswell from academia, a groundswell from civil society, It was led by HEALER, which Angelika will talk about. And HEALER, this Healthy Living Alliance, really took on infant and young child feeding on the basis that Nestle was flaunting the regulations, on the basis that Nestle was still engaging directly with mothers despite these regulations. And so this sets the scene for this project called Nourished Truth. Next slide, please. So what really gave this impetus around civil society and civil society engagement with the regulations? Because like I said, the regulations was really around the nutrition fraternity. It was not known widely. But then two things happened in South Africa during 2021, 2022. The first one was the fact that Professor Lindiwe Sibanda, who is known regionally in Africa as well as in South Africa and attached to the University of Pretoria. She was appointed to the Nestle Board of Directors. And this is a clip that I've taken. This post comes from Nestle itself. So on the 18th of February, Nestle announced that they had appointed the director to the Board of Directors. In the context of the regulations, this was a violation of the regulations. In the context of conflict of interest, this was a huge conflict of interest. And the groundswell was really around bringing attention to both the regulations as well as industry interference in academia and in research. Because at the university, Prof. Sibanda was actually leading a very big regional research institute that also looked at infant and young child feeding. And so that conflict of interest was blatant. And so through the South African Civil Society for Women, Adolescent and Children's Health, this objection became very much a wide media objection. It was being discussed in international circles. It was brought to the attention of UNICEF and WHO at the time, as well as Nestle itself. And that foregrounded the campaign called Not Today Nestle, which was campaigned by HEALER, which is a civil society organization. And part of HEALER and the work that was already being done by the Civil Society for Women, Adolescents and Children's Health called SAXCO Watch, this gave the breeding ground for like-minded institutions, like-minded organizations and researchers to come together to actually push back on the influence of industry. Next slide. And so with all this impetus and background, this is really a way to tell you the story that garnered energy, garnered passion, garnered the resistance to the influence and the interference of industry. And so at the time, while Katharina was talking to Nigel from WHO, while WHO was doing this multi-country study, while Not Today Nestle was being bred from the ground up. So we had the high-level global actors as well as the local NGO actors really coming together, as we would say, the stars were aligned. So in early 2001, WHO contacted SAXCO Watch and asked SAXCO Watch whether they would be interested in taking on a project to see whether advocacy and whether we could systematically use advocacy to do the pushback on industry. And so through a consultancy with the Family Laws and Rosenquist Foundation, myself as a consultant and thinking about this project, thinking about leading this project, started to work with Family Laws and Rosenquist to kind of put a project together so that we could pitch it to an organization in South Africa. We had a working group already around it. We had SAXCO Watch, we had other interested NGOs that were working in the field of child health and nutrition. And we started to talk about how maybe take this project, which was supported by research coming out of WHO multi-country study, supported by an organization like the Family Laws and Rosenquist Foundation as a co-creator, and the academic excellence that was already in the country, and the passion and the resilience of the NGO sector. How could we bring all of this energy to bear on a project? That's how this project came together. And so we set off on putting an MOU together and started to really pitch this project to 3 or 4 organizations, All of them were academic organizations. And then the UWC through the Center of Excellence for Food Security, they then decided that this project was viable. This project ticked the boxes for academia. There was an academic research question. There was a understanding of using research to change the human condition. And so this is how the project then came together. So the timeline that I'm going to be telling you about is really from the time that the project was located at UWC and how we built the project up until it was handed over for phase 2. Next slide, please. So establishing the project, firstly, I want to say was built on trust. Many of us have been working in the field. I told you the history now about PMTCT from 1999 already. I was in the field as a data collector. We were working in a multi-sectoral, multi-disciplinary setting in that context. And the project was hosted by UWC at the Center of Excellence for Food Security. I then moved from an academic institution and moved to UWC to take on this project as project lead. My colleagues at Wits, both from community pediatrics, so that was a medical facing unit, as well as the School of Public Health, came on board from Wits University. The South African Medical Research Council, the PI for the multi-country study that was done in South Africa, was brought on board. And then 2 organizations, civil society organizations through Grow Great and Healer, joined what we called the technical working group. And what set out as a intersectoral collaboration, academia, civil society, international organizations like the Family Loss and Rosenquist Foundation, as well as WHO, came together to talk about the rules of engagement. So that first phase of setting up the project was about co-creation, bringing all the ideas into a melting pot and bringing the best out of all of the partners. So autonomy and equality. An MOU was set up with University of the Western Cape because there was a lot of funding that needed to be managed with a good, strong governance structure, and academia supported that. We had a steering committee, and I'll talk a little bit about the structures both of the steering committee and the technical working group. And most important, not all of the first round of partnerships were aligned to the international code or the regulations called R991. Not all of the partners were aligned to what this project was trying to achieve. And so along the line, we also did lose partners along the way. And then finally, we had to have agreement as a collective around the objectives and the milestones. Next slide, please. So with all of this coming into play, I just want to give you the structure. We had a steering committee, which was made up of UWC, which was the academic partner or the host, Family Loss and Rosenquist Foundation, and WHO was a steering committee giving us guidance, strategic guidance, as well as governance. There was resource oversight and management support. Both the steering committee and the technical working group also engaged with National Department of Health at a much higher level, both through the Center of Excellence for Food Security, as well as the partnerships that were built on other projects. So not just this project, many of us were working across different sectors, both in child health, child nutrition, community development, and advocacy. And so I think that when you are bringing multiple partners into a space of working on a project, what is important is that the members can adhere to principles. The first principle was technical and process guidance at all processes was agreed to as the technical working group. That technical working group then presented its strategic guidance back to the steering committee, and the steering committee gave support or gave us extra questions to answer. But throughout this project, we brought to bear both the technical expertise, the intelligence, the experience from the ground, as well as the lived experience of the partnership. Next slide. So in developing our first proposal was to seed this within academia, and through the academic processes of setting a research question, agreeing to the methodology, as well as the ethics of doing research. We developed an umbrella proposal which had sub-studies for the different target audiences. In the beginning, we were going to talk to caregivers, mothers, parents. We were going to talk to the health sector. We were going to talk to the retail sector. We wanted to talk to the media. We wanted to talk to civil society. So the original proposal was much larger with these sub-studies. And these sub-studies then had to be taken to a working group with more consultation with other role players, with other partnerships. And then we started to really hone down onto who exactly were we going to talk to and what was the question we were trying to answer. So we wanted to explore what are the strategies that the infant formula industry employed to influence those that influence mothers. So we then forego going to talk to mothers, but we were particularly going to talk to who do mothers trust. And we knew that mothers trusted the health system. We knew that mothers trusted pharmacists. They went to the retail to get information. And so we then started to hone the proposal around these core influences of mothers. The submission was done to UWC Scientific Review Committee, and that was approved in late July. Thank you. Next slide.
Chantell,
So
you've
once
got
we
about
had
5 minutes left. Sorry, you've got 5 minutes.
Wow. So just to give you a brief overview of the methodology, and you'll be able to read this more in depth in the handbook, was one, to identify the sectors, develop your questionnaires, start to think about how you were going to codify those questionnaires. And this is where the relationship between the operationalization that Katharina talked about, the research findings, and the experience of on the ground really come to bear on how well that information can be used. One, to generate the analysis, and two, to start setting strategic priorities for your strategy. Next slide. So in doing this, I just want to say you can read in the handbook, but to show that we had consulted widely on who we would interview and who we thought we would be using. The researchers did not do this. This was outsourced to a service provider, and that service provider was a marketing company. Next slide. So for the marketing company, they finally, because of trying to access people, we had thought about 120 interviews, but the final sample was around 72 interviews. It was imperative to take a marketing survey company because one, academia is quite stiff. Two, most people are very suspect about research, and doing a market survey was much more appealing to those that we wanted to speak to. The company itself did an excellent job of actually collecting the data, but where we had real trouble was really looking at the data and making sense of that data, kind of analyzing it and putting that coding framework around the data really took the team from Family Loss and Rosenquist, the researchers, and then the expert or the subject matter experts to help us make sense of the data that was coming through. Next slide. And so the key findings of that first phase was that we identified three major drivers. Firstly, there were activities that the commercial milk formula companies were using. So they were making inroads. They were presenting themselves as a resource back to the sectors that we had talked to, being the medical fraternity, the media, and the retailers. They were also presenting themselves as a solution to many of the problems that they had created. So the medicalization of normal child behavior was a big driver. So if your child cried too much, we had an answer for you. If your child was burping too much, we had an answer for you. So that was a major driver. And then finally, also for our target audiences, they were really needing information. And who was giving that information came back to the commercial formula companies. This was a very rudimentary model that we developed in phase one. You'll find a much more developed model on page 26 of the handbook that really unpacks four major drivers, and then you'll read more about that. Next slide. And so once we had got down to this, the biggest story that came out of this, both in terms of the multi-country study as well as other research in the literature, it is always presented that the formula companies are pushing their messages or pushing their product. The reality is that the target markets, being the medical fraternity or the retailers or the media, is that formula companies were actually providing a service, both in terms of information, a product, that was consistent, that was reliable, that was professionally presented. And unfortunately, in the breastfeeding world, both with civil society and academia, we were not holding up. We were not providing information. We were often inconsistent and unreliable, and we often didn't have the kind of information that our target market was looking for. These are the last two slides that are coming up. The last second slide. Next slide, please. So with this brief, we wrote up a brief that was handed over for phase 2. And phase 2 was really supposed to take the evidence that was generated in phase 1 to develop the strategy for the advocacy, the actual advocacy. And this is still relevant. Even 3 years later, we see that our president has focused and doubled down on the first 1,000 days. And what that really means is that the first 1,000 days is focused on infant and young child feeding. And if we don't counteract the influences that are limiting our activities around infant and young child feeding, South Africa is never going to meet the 2030 milestones. Thank you, Angelika, even for the extra minute.
Thank you so much. And it's so important to really understand the context behind it. I mean, it's safe to say that this project is very complex. There's a lot of history to it. So as Dr. Witten mentioned, I'm going to go through what happened in phase 2 when the project was hosted under the Healthy Living Alliance. We are a civil society advocacy group, so it really did work well to go from this very academic sector to be able to get to campaign planning and advocacy material development in phase 2. Sorry, next slide. And next slide. So we had 2 different elements that we needed to cover in phase 2. The first was to create the advocacy communication materials. So this was really all of the messages that would be used within the campaign, as well as looking at the gaps where what was needed. So for example, from phase 1, it came that a lot of healthcare workers don't understand our regulation R991 that protects or that restricts the marketing of formula that companies need to follow. So we really followed a very rigorous process. We hired a communication company to be able to develop messages, and these messages were really centered on different healthcare workers working in that have influence on feeding recommendations. So doctors, dietitians, nurses, etc. We hired this communication company to develop the messages. Then we developed a protocol to be able to see how we could actually pilot these messages with healthcare workers. And then we piloted these messages. And it was a really interesting process to go through, because sometimes when you see the research, you see what we need to actually achieve. And then when real people see how you're actually going to be talking to them, we had to really change a lot of the ideas of how it's going to be, how we're going to actually be able to implement. So after piloting, we were able to finalize these messages. And now we have this wonderful pack of messages for healthcare workers, as well as a regulation healthcare worker guide, which is a really important tool to be able to understand a very complex legal type of jargon of a regulation. And I do just want to also thank our advisory group that we set up at the beginning of the project, which included a lot of the technical working group members from phase 1. So there was a great continuity of the project, as well as then some communication specialists and new NGOs to get a fresh perspective. Next slide. And then we also had to, of course, create a campaign from all of this wonderful strategy, wonderful research that had happened in phase 1. We had to look at what had been developed and actually create a campaign strategy. So we created this strategy, and in there was really the project background. What are our goals and objectives? How do we want to see this being implemented in South Africa? And really looking at that graph that Dr. Witten showed us, where there was those key priority areas that we needed to focus on, and how we could create almost a small theory of change, of getting from point A to B and ensuring that we can actually see change being seen in the health system. And then, of course, just lots of details of what kind of content, what kind of activities need to be happening within the engagement and the advocacy plans that we had. We then also needed to, of course, create a campaign budget to see how much we need for implementation. And this is also a very thorough costing plan, where it had the overall budget, time plans or timelines that we needed to follow, and then direct examples of the preparation phase, engagement and advocacy activities, and how much we needed for that. And then, of course, because we need funding for any kind of implementation, we need to understand the donor landscape analysis and seeing what kind of donors we could approach in the future to be able to implement this project, and really thinking through how we can actually approach them, as well as what kind of activities we can use to get money to be able to implement. As we all know, in the NGO sector, it is really needed. So just to also say, I mean, we've heard now from Dr. Witten, and we've seen the phase 2 activities. And this was why it's so important to have something like the Nourished Truth Operational Toolkit. Next slide, please. To be able to really take all of this information and work from policy and research ideas, and really all of the information from the collaborative phase to practical, impactful action. And we really hope that this operational toolkit that I'm going to quickly run through how it works is going to be helpful for different contexts, different countries, different governments, different NGOs. Anyone who would want to take on a similar project can actually just use this as a very practical guide, an easy user-friendly guide. And it's really also, it's meant to be adaptable. It's not supposed to be that exactly how it worked in South Africa will work in a different country, but it is something that is a helpful tool, hopefully, to use. Next slide. So just to give you a quick run through of this handbook, or the toolkit. The toolkit comes in 3 different parts. So you're seeing on the slide the actual handbook, which is a PDF document, where you can go through and it will give you all the details and the steps of how we got from phase 1 to phase 2, etc. Then we've also developed some process flowcharts to help you out to understand just in the bigger picture how all of these things work. And then we've also developed many templates and examples for you to be able to use, so that it is, again, just this straightforward, easy approach instead of starting from scratch, that you can see how it can work. Next slide. So if we just look at part 1 of the operational handbook of these within the toolkit, again, I just want to emphasize that the establishment of the project, phase 1 and phase 2 are included in this operational handbook. Next slide. Where phase 3 is more the implementation. And of course, this is going to look very different in different contexts. But within this operational handbook, this PDF document that you would receive, it's supposed to be very user-friendly, and also it's really being created that you can click on it and you can go through different sections. So for example, if you see a purple arrow like you're seeing on the screen, if you click on it, it'll take you to the different sections. Of course, I mean, you've heard how much we had to learn from the South African experience, and how much we've been able to reflect on why certain aspects worked and why they maybe didn't. So whenever we had any kind of reflections from South Africa, we also added that into the box, a text box like you're seeing on the screen. Next slide. Then part 2 is the process flowchart. So within the handbook, there will be the little icon, that purple icon that you're seeing, where it refers to the flowcharts. This will take you to a different document which has these flowcharts in them. So there's flowcharts for establishing the project, phase 1 and phase 2. And it's really also just to show you the overall picture, so that you can be able to guide yourself through the handbook quite easily. It's showing what actions need to be taken, who might be responsible, what kind of outputs you might be aiming for, and then where possible, if there are any templates available to be able to help you through this, then you can click on that. Next slide. And then finally, there's the templates and examples, part 3 of this toolkit. So again, within the handbook, there will be these little icons. So either an empty page, purple icon, that if within the handbook, if there is a template available, that you will be able to click on this and it will open up for you. And then there's the one there where there's some writing, which takes you to an example. An example is more of a end product, so that you can possibly aim for, just to give you an example of how it would actually look. And these templates, I mean, you can see on the screen, there's plenty of them. They're really, really created for to make it as easy to edit as possible. They range from things like meeting agendas all the way to the very complex costing structure that we had and the budget that we created. So really just so that you can click on it, there's places where you can edit it, and then work from there. And whatever templates are and examples are helpful to you, you use, and with picking and choosing. Next slide. So if you would like to access this toolkit, if you've got very quick fingers, you can use the QR code. But otherwise, there is going to be a link in the chat box, as well as you can visit www.nourishedtruth.org. And then I also just want to say a huge thank you again to our advisory group from Phase 2, as well as then give acknowledgement to Bonnie Avert, as well as Dr. Katharina Lichtner, who co-authored the handbook. So thank you very much. We are now going to move on to see, we've now seen how this whole process unfolded, and we want to explore whether these types of ideas or this type of projects can actually cross countries, cross different contexts. So I would like to bring in Prof. Richmond Aryeetey, who is a public health nutrition specialist and the head of Population, Family and Reproductive Health Department at the University of Ghana. So Prof, are you there? Hi. I would like to just open up the discussion and just see, you've heard, you know how complex this is, and we know that the CMF industry has so much influence for breastfeeding in different contexts. So from your perspective, what is Ghana's experience with the CMF industry and its influence on breastfeeding? And do you see any parallels or any challenges you might see compared to the South African experience?
Thank you, and exciting that we are having this conversation, because for me personally, in my career, this is one of the areas that I find very exciting, because it enables you to bring together different sectors, and it's actually different sectors that represent the experience in Ghana. So a little bit of walk through history, as we saw in the South Africa case. I think there are a number of things that are similar. As I talk about them, you would realize. So first off, back in the early 90s, that was when Ghana first started to look at how are children being fed, very young children, and the analysis supported with the technical input of UNICEF quickly showed that a lot of Ghanaians, almost all Ghanaian children, are breastfed. The problem was that they are not breastfed according to the recommendations around that time. This is early 90s. And with the help of UNICEF, a dedicated desk was created in the Ministry of Health to start looking at how do you enable optimal breastfeeding. But then one of the things that became very clear was the influence of formula and other foods that were fed to children for cultural and other reasons. In the case of formula, Ghana translated the code into a law that came into effect in the year 2000. We called it the breastfeeding promotion legislation. This had all kinds of provisions to address issues of inappropriate marketing, which was going on both through commercial outlets and through health facilities with the aid of health workers. And it became very clear that the health workers who were doing that for two main reasons. The first one was just lack of awareness and the fact that many people were not aware of the harms that inappropriate marketing was causing. And then the other one was conflict of interest. The law was strictly enforced from the beginning. And so even up to today, you would not see on TV or radio marketing of formula, commercial formula. But then industry responded very quickly by changing their tactics. And we've heard how that was happening in South Africa as well, where they were using ways that compromised health workers by providing free samples. And one of the major routes they were using was to come in the guise of training health workers so that they would become a conduit for promoting formula. In fact, that's one of the big challenges that we continue to face, and that is that women give birth and health workers have formula that they give to mothers, and this is under the table, more or less, and they collect money directly from mothers. Today, that same kind of marketing goes on, but in a different form. Mainly, a big part of it is through social media. Social media has become a big outlet for promoting that. Part of it is because of urbanization and increasing of the middle class that is beginning to yearn for different ways of exposing their children to different foods that they encounter on social media and other media as well. So essentially, that is what the story looks like. I think there is also the issue of poor capacity to implement code monitoring, because in Ghana, the law mandated the Food and Drugs Authority to do that, but the Food and Drugs Authority is an organization that is not very well linked with the health system. So there are gaps that then the companies that are manufacturing or those that are marketing can take advantage of. I think basically this is how the situation looks like in the Ghanaian context.
Yeah, thanks for those reflections. And I mean, it just sounds so similar to the South African context, just of course, very much planned by the industry of how much they can take advantage of the situations in different contexts. And I mean, we see that there are violations of regulations, but also that often they're very clever. They also know the regulations very well, and they can find their loopholes where it's so close to a violation, but it's not a violation, so they can get away with it. So, I mean, it really is an important thing, and especially within the healthcare space where mothers need the healthcare workers to be supporting them as much as possible when it comes to breastfeeding. Prof, I also just want to hear from you. So, I mean, I don't know if Ghana has any kind of these advocacy type of ideas going yet, with when looking at the Nourished Truth project, or if there's appetite for it within different stakeholders that are quite important to start off something like this. And now also having seen this handbook, do you think that this is going to be quite a helpful resource, or how adaptable do you think it will be within your context?
So in the last few years, there has been interest in enabling mothers to be able to especially initiate breastfeeding early on time. One of the challenges we've had is having the groundswell of civil society advocacy to sustain this. Very early on in our trajectory regarding the code, there was an organization that was playing that role, Ghana Infant Nutrition Action Network. But in the last few years, it has not been very active because of funding. Interestingly, there has also been a transition in all the people who are leading the front line. Many of them have grown out of their careers and retired, and we haven't had a replacement of that going. But among the government institutions, there is high interest in my encounters and in my work with them. There's a lot of high interest in that. The main challenge has always been funding to implement activities and to carry out the mobilization that is needed. But I think that this is a very useful tool that can serve a useful purpose of creating, first of all, the opportunity to understand what is happening and to document that. To the best of my knowledge, there has not been any formal consistent evaluation of the role of the role that the companies that are working in formula are playing. We have always focused on the breastfeeding side, but we have not looked at it from the formula side. And I think this tool presents an opportunity to first bring light to the issue and then drive the advocacy.
And I mean, again, it's really trying to help not have to start from scratch. There are
Right.
supportive tools and everything there to be able to help drive this. And I mean, I think every country probably can find a really powerful group of advocates, ranging from NGOs, academics, everyone, government agencies, everyone that really wants to fight for increasing breastfeeding rates in whatever format that looks like. Thank you so much, Prof. And we are going to go on to the Q&A session. So I do see that there is a question about the cultural dynamics of Africa, and if we're looking at a project like this, how are we considering piloting in phases across regions so that both control and experimental growth outcomes and differences could showcase evidence for future meta-analyses? So this is a very, it seems like a very academic question, but I would like to ask Dr. Lichtner, maybe also just to reflect a little bit now that this toolkit has been launched. What is Family Loss and Rosenquist's Foundation's plans of supporting maybe other African contexts or other world contexts, and also just supporting it or helping other areas be able to implement this?
Yeah, thank you, Angelika. Maybe one reflection again on the handbook to maybe put it into a little more context for everyone on the call. I think where we're driving at, and I think it came really nicely out of the reflections of what happened in South Africa versus what Richmond just has talked about, what the situation in Ghana is. So I think everybody kind of feels like, yeah, it sounds similar, but it's not quite identical. And I think that it's going to be the experience of everyone on the call if it's a different country. So, and the reason why we're driving this type of work forward in the way we do, specifically putting it into a handbook, is that we don't believe you can take the work that has been done in South Africa as a case study and just transport it over into Ghana. The system is slightly different people on the ground. The health system works a little bit different people are engaged, different histories. So you don't have an identical situation. So you cannot translate the solution from one country to the next. But to come to a specific solution for a country, the process of doing this systematically, so you save time, so you don't forget important things because intuitively one didn't see it, to have the tools at hand and not have to redevelop every single time, and from scratch how one goes about finding the right strategy. This is why we've done the handbook. So what you can bring from one country to another is the process of how to find the right solution. And the process of how to do it well now that we've developed it in South Africa. And the handbook encapsulates not the solution, but the process. And that allows every single country to go through the steps that we've tested, that we've tried, we know they work. Use the templates because you don't have to reinvent the questionnaire. You don't have to reinvent how you analyze the data and so on and so forth. You have templates of how to build the strategy, how to move on to build the actual messages and narratives you want to provide in your country. That's going to speed up the process, which makes it a lot more cost effective, which makes it a lot more effective overall, because it allows you to look at all the parts of the entire system and capture all the problems before you actually develop the actual communication strategy. And that makes it a lot more powerful. And this is why we've done the handbook. So the development has been fairly complex, and has taken some time because we started with nothing and had to create the process, the concept, the idea, the campaign, and everything. But now that this is done, it should make it very straightforward and very efficient for countries to develop their own campaigns in the context. So I feel really strongly about that fact. So it shouldn't be complicated anymore now that the handbook is available, even though getting to the handbook was fairly complex. So don't confuse the development time and all the things we had to go through with what it means now to use it in your country, right? So what does it mean from our point of view? For Ghana, we've just completed last year the operationalization of the breastfeeding policy. So that's a 5-year plan. Nourished Truth is part of it because obviously, as Richmond has said, Ghana would profit as well from an anti-BMS campaign because it suffers very similar problems that were identified in South Africa. But that Nourished Truth stands for itself, so it can be done in any other country without having operationalization of an entire breastfeeding policy. So what are we doing from the FLRF side with it? I think this webinar is obviously one of the activities. I think we will be presenting it on conferences. It's freely available on the internet. For example, UBORA Quality Institute, they are a group of consultants that can support governments also outside of Ghana in implementing these types of operationalization activities and developing their campaigns, because they have been through a number of rounds now within Ghana. So they're very skilled in working through these processes. So we are going to provide and continue with webinars, continue with teachings. We are creating and there will be more on this in the coming years. We are actually working on translating and creating a lot of teaching and also information material to create a counterweight to what the formula industry is providing. Because apart from the activities, what's really lacking, and Chantell has outlined this really well, is that we don't have anything equivalent to offer to nurses, mothers, public health workers, community health workers, practitioners on the ground, to offer them as information material from the breastfeeding community compared to what they find from the formula industry, and that has to be corrected. And we're working on this in parallel, and this will all be amalgamated into, for sure, for the practitioner side, into a training tool and a reference and support tool, which rudimentarily we have already, but we're currently with Richmond in a project to update this, to transform it into a training tool and reference tool that is going to be very helpful for practitioners on the ground, specifically in Africa. So there's more to come, and Nourished Truth will be integrated into that as well. And at the same time, we will pitch it at conferences. We'll hope that we can replicate it in other countries. And of course, those countries that are interested in doing it, they can also contact us, and we can think through together how they can best go about it. Thanks.
Great, thank you. Are there any other reflections quickly? I see, Chantell, that you have already maybe answered this in writing, but one of the questions was, from the South African experience, what were the turning points that shifted the advocacy efforts from awareness raising to actual policy or system change, and how can other countries maybe accelerate that going forward?
Thanks, Angelika. So as I said in the response, for South Africa, we already had the policy environment, but I think that you can use as an advocacy strategy. You can gather the evidence, consolidate that evidence into your messaging, into your advocacy pitch to actually move the policy. So, for example, if we hadn't stopped the free formula, this Nourished Truth project could have gathered the information that we needed on how to counteract, whether that was at the government level, whether that was in the health fraternity. There's a lot of questions about where does the nurses, the doctors, that dietitians sit. And the reality is that they think they're doing the right thing. They think by sourcing information from the infant formula companies that one, it's scientific, that came out very clearly. A lot of people said they have more research money, so they're obviously doing the best research. But we know obviously from the Lancet series, they published their own research, they flaunt their own research, it's not good, credible research. But this is how our health fraternity has been influenced. And we need to counteract that. And I think this is what the handbook will be able to help you. Once you've done your, let's call it the lay of the land, you can do the analysis and then you can see, oh, where's the gap? This is where we need to act. Thanks, Angelika.
Yeah, thank you for that. And then also just sort of piggybacking on that idea of how much the industry actually tries to educate healthcare workers or even mothers to an extent. There's a question, Prof. Aryeetey, to you. In Ghana, is there any pre-service training on breastfeeding at the universities for healthcare workers?
So I have actually tried to answer this as part of the BBF work that we did. We searched through the curriculum and there's very little opportunity for that. From the nurses, the curriculum for maternal health only has about 2 hours of content for breastfeeding. So pre-service breastfeeding training is very limited. So most of the training for breastfeeding happens after they are employed. So that is in-service training. That is what is the current situation.
Yeah. And I think we probably see...
please. The training tools available for in-service training, I don't think are really in line with what works in a modern work environment. They're very heavy, paper-based, they're lengthy, they're not well modularized, not sufficiently IT-based, or let's say mobile-based. So I think there's a lot to do for the breastfeeding community to actually enable nurses that want to learn, which is the basis of changing something, to do this more efficiently and better integrated into their work days.
Yeah. I mean, the importance of pre-service training as well as once in service, it's so difficult to actually find the time for healthcare workers to be able to learn new skills. So it really, really is important. We have a question here for you, Prof. Lakati, just a very practical question about the Congress. Is it in person only or can it be joined online?
Thank you. And just before I answer that question, what Richmond said about the content in terms of breastfeeding is the same across also our training institutions. So for us, really, this is an opportunity to use this toolkit, and we shall be having it in the Congress, as Katharina said. So for the Congress, this is an in-person Congress, but there would be recordings that would be available later. Thank you.
Great. Thank you. We do also have a question here, or a few questions coming through now, maybe looking at breastfeeding a bit more broadly about the informal sector, emergency situations. And I think I've got a question for you, Dr. Witten. In phase 1, because breastfeeding is there's so much to it. There's so much work that needs to be done to actually increase breastfeeding rates. In phase 1 of the project, how did you manage that? How did you manage the conversations that were happening around supporting and promoting breastfeeding, where this project really looks at protecting the breastfeeding environment? Do you have any reflections for that? And also even just looking forward, how to sort of manage that? Because it is, we know how emotional breastfeeding can get and how important it is to different people and how many barriers there are to successfully breastfeeding.
So from the project's perspective, we had one research question, and I think that's what is good about being in academia, is that you're focused on the research question and you're focusing on answering one question. And so many of us working in the project and for us working in other organizations, the promotion and the support was continuous. It was still happening. For example, Angelika and myself serve on the Department of Health's technical working group. So in that part, we're still doing a lot of the work that is promotive and supportive. But in this particular project, what we were after was understanding, digging deep into how industry operates in these systems, particularly in academia and the health system. And so we kept true to the mission. And I think the tell is about having the handbook. And so I think don't get distracted by what others want you to do. If you've got a mission, stick to the mission. So that's my answer.
Yeah, and as you say, I mean, there is so much ongoing work surrounding this. It's not, it is good to actually also just have a clear goal for the campaign. Are there any reflections that any last minute thoughts coming from any of the speakers? I think we've answered most of the questions and tried to group anything. Please, Prof, go ahead.
Yes, a question that I've seen coming asking about freebies and issues around conflict of interest, which I think is a very big driver of this challenge. And I want to just share a very small story about myself, because this is something that you would never think would happen to you. But early in my career, I got invited by Nestle to give a talk, and the talk was on non-communicable diseases. And I landed straight into the middle of a promotional meeting that they were having. And they had invited a lot of people from across the health service in a very big hotel. And among the audience were a lot of my students. I talk about non-communicable disease, and then after that, all that they were talking about was promoting products. It was a big wake up for me. So this is the kind of thing that everybody needs to be aware of, the vigilance that is being talked about, but it also has to be something that is systematically determined so that professionals don't fall into that kind of trap.
And that is very important. We see it definitely also in South Africa with that specific company, and then, I mean, plenty of others. Katharina, would you like to go ahead?
Yeah, I've been reading with one eye some of the questions, and one of the questions was in refugee or low resource settings, how can we balance emergency feeding with protection of breastfeeding? And that is a big problem. We recognize that as well. However, that's not encapsulated in the handbook of the advocacy campaign, but I just wanted to let that person know that we're actually working on another project, which is again, handbooks on how to support breastfeeding in humanitarian crisis settings, different settings, and that work is well in progress, and we expect results towards end of September, October-ish. So we probably have a webinar on that question at that time, but that is more operational on the ground. And again, yes, there is a conflict between formula feeding and breastfeeding specifically in these situations, but we hope to give recommendations and operational guidance to that questions as well, which, however, is not addressed in the handbook for an in-country campaign, which is more for pushing back formula in the going concern normal environment of everyday life, not specifically for emergency situations.
Thank you. Prof. Lakati, would you like to go ahead? I see your hands raised.
Thank you. Just to say that from an academic or a training point of view, because I work for a university, the opportunity here is to strengthen the training of future healthcare workers, because the content has always been quite limited, such that it is assumed the breastfeeding is something that is known, that people can freely do, but you'd be surprised about the changing population dynamics and the fact that the marketing companies are working really hard. We are having a population that has been influenced from a very early stage. So by the time they come to nursing school or medical school, they already have formed some opinions that the training is going to help. So this handbook is really going to be useful as additional material for training institution. Thank you.
No, that's great to hear. It's great that we're able to support others in the future through all of this work that was done. And then also, I mean, there are plenty of other questions that might come up in the next coming days after you're reflecting on this. And we have also within the handbook also offered the opportunity of different emails that you can email from Gila or Family Loss and Rosenquist Foundation. That please be encouraged to use that so that we can direct those kind of questions of giving as much support as possible in the future. This is not where this ends at all. It's really just the start of a lot of activities that are going to happen around Nourished Truth. So I really would like to thank everyone for everything. If all the panelists are happy and they've said everything they want to say, we are 5 minutes away from ending the webinar. So I mean, if we just think about the takeaways from this, is that, I mean, strategy is so important. We know that there are just so many different issues within different countries, and we need to have very good, well-resourced, well-thought-through strategies to be able to get the change that we want. We also, I mean, I can just hear the strong foundations of a project are really important. We need to have the correct people in place that are working towards the ideas of this kind of project. We need to find the correct type of research questions. We need to really think through the academic process that comes with a project like this and make it as actionable as possible, but based on a lot of evidence. And then hopefully we'll see with the tools of the handbook and just looking at tools like that and how, I mean, we in South Africa can help so many other countries. And once those countries or areas have been able to start projects like this, that we can all become a good network to really combat this issue. I mean, the industry is very well resourced, as we've mentioned. It's very well organized. There's plenty of multinational companies out there that are working almost also probably together quite closely or using similar strategies. So if we as public health experts, as healthcare workers, as everyone coming together, we can also create a very strong network to be able to combat this issue. So I would like to say a huge thank you to all the panelists. The conversations were amazing. It looks like there was a lot of great insight coming from the comments and also all the questions that were asked. Thank you to everyone that was part of this webinar and came in as well. And then I see that there have been a few questions about certificates of attendance. So once again, there has been links being made, but if you follow the link of the lactahub.org/certificate and use today's date as a passcode, then we will be able to give you out certificates for today's attendance. So again, thank you so much to everybody involved. This, as Katharina mentioned, this is only the start of a lot of Nourished Truth conversations. So we hope that you can follow all of these different conversations and carry on with the good fight against this marketing and to protect more babies with increased breastfeeding rates. Thank you so much.
Thank you for a great notification. And thanks for everyone on the call. Thank you.
Thank you. Bye-bye.